So today we're going to talk about provider directories on the HCBiz show. And this is a problem that I've spent the better part of the last 2 years digging into very deeply. And it is a problem that I believe is, at least outside of the payer community, I think it's a problem that is very underestimated in terms of A, its importance, and B, its complexity and difficulty in terms of solving. And I like to refer to it as the ultimate paper cut problem in healthcare. And if you think about it, provider directories, it is the underlying data about the providers that an organization is working with, paying, whatever the case may be. And if they don't have that right, they're building all downstream operations on top of this really broken set of data, and it manifests itself in all manner of ways. And what I've seen, at least out there in the wild, is that while it's known, as I said, it's not respected as a problem, but it is a known problem, and it's just accepted that this is one of those types of problems that you throw project managers at it, you throw staff at it, you throw money at it, and this waste is just budgeted in to the process of doing business. So when you look at it from a grand scale across the country, I think it's one of those things that if corrected, it could serve to make a huge difference for the business of healthcare in across that aggregate in a huge way. So it is definitely an important topic. We're going to come at it a lot from the payer perspective. And hopefully elaborate on that and talk about some of the other areas of the business that are impacted by it. So with that, we have, as always, my co-host Shahid Shah from Netspective on the line here today. And Shahid, you're also the entrepreneur in residence at the American Health Plans Institute for Innovations as well, and working on this problem quite a bit. So thank you for coming.
Sure, happy to be here. And it's the America's Health Insurance Plans, as you know, is the largest member association for health plans. And I am a advisor and entrepreneur in residence for just a small component of the Innovation Lab. So that's run by a gentleman named Rahul Dubey. He does all the hard work, and I come in and give him a little advice here and there.
Gotcha. So what brought this topic up here is very recently, California launched a statewide bill that is basically going after all of the payers across the state. And this is just, the feds did it earlier this year with CMS announcing some penalties for Medicare Advantage plans and anybody on the health exchanges. If they don't keep their provider directories up to date, they face fines. California is now coming at it and not just looking at the public plans, but they're going across the board, and they are effectively covering every plan that operates in California and facing some fines and some steep penalties. And my question for you to start this off is what is it about provider directory data? What is it that, if it's out of date, would warrant somebody being fined for?
Yeah, that's a great question. I'm glad we're talking about that, because a lot of people don't understand why it is that the insurance plans get fined, even though the inaccurate data is actually coming from, in some cases, or in many cases, depending on the region, from the providers. And that's because if you think about it from a commercial perspective, the contract that you and I sign for a health plan, when we say that we want to use health plan A or B, whether it's Humana or Aetna or United Healthcare, they are expressly telling us that when you sign on with me, you can see these physicians in these areas at potentially these prices and for these services. Well, it turns out that after we signed the deal, if the provider directory was inaccurate, it means that it'd be just like if we go to a store in which they've offered a coupon for a product at a particular price, and we show up at the store and say, okay, guys, I want this product for this price that you gave me the coupon for. They can't just say, oh, we were kidding. We didn't really mean that we had this product, and we didn't really mean that we had this service available. But thanks for coming to our store and buying some other stuff, right? That's called a bait and switch. So when you think about it from a fundamental perspective, it's a commercial problem when a insurance plan accidentally, and I mean, no sane insurance plan would on purpose do this. But because of the complexity that we're about to talk about in this hour, it happens that when the patient has agreed to sign up to a health insurance plan, And the plan has said, I have these services with these providers in this network and offering these capabilities. They have to be able to meet those obligations. Otherwise, it's a commercial contract problem. Now, in some cases, the data is accurate in the sense of where a provider is located, but they're not accepting new patients. Again, it's a flaw in the contract then, because you're offering a product like access to a provider, which is what the plan is doing. Yet when after the patient signs up, that provider is not available or is not taking patients, clearly a member has been offered a good or service that they are not going to be receiving for the payment that they're making. So that's why CMS and California, they're all taking this problem very, very seriously, enough to fine the insurance companies. But what we're finding is that there's really no way for the insurance company other than, and that's why the AHIP trial pilot that's in being run this year, to find out, what could be done. Right now, it's a very traditional model where health plans basically have to call up the providers every N number of days, Y number of months, a Z number of quarters, just to get them to tell them, are you still there? Are you still accepting patients? Do you still accept our insurance? I mean, these seem like such innocent, simple, easy to answer questions, but as you know, Don, that they're not simple at all. It's very, very hard to get these provider directories accurate.
Yeah, absolutely. And one of the things you got to think about too is it sounds like one simple call, and in our industry, maybe a send of a fax, but you got to put yourself in the doctor's shoes then too, especially at a small practice. Is most of these doctors are working with 15, 20 different payers, and that means 15 or 20 different phone calls coming in. And as a provider, having to update all of those all of the time, it's natural that some of those are going to get lost in the daily melee of trying to practice medicine. So it's that in and of itself makes this an interesting problem.
Absolutely, and it's unsustainable. There's no way that you can have dozens of health plans calling up each provider and the provider being able to respond. Providers absolutely want to give accurate data whenever they can. Plans want to get it whenever they can. The problem is we're trying to solve a 21st century problem with 20th century technology. And really, if you think about the data that exists in these systems, when you think about electronic health records, they're already managing the providers that can access their electronic health records. When you look at other digital health tools, even some of the tools that you've worked on in the past, you manage provider data. CMS manages the NPI, the National Provider Identifier database. So there are pockets of data that already exist in the system that if we were to bring them together, and that's some of the work that the AHIP Institute members are helping to start and work with providers on. If we can work as a team, I shouldn't say if, the only way to solve this is providers must work as a team with payers and vice versa. And we've got to get out of fax, phone, etc., into a more modern capability, starting with CMS's data, which is the National Provider Identifier. Now, this all seems like it's something easy that we could get started, but it's not. And the networks don't exist where we can pass this data back and forth as easily. So, you have existing network providers such as MDON, which is now Change Healthcare, such as SureScripts, which manages prescriber information. There are a lot of companies that have this capability that if we were to corral them in the industry, pull them together, show them how we can work together, just like 10 years ago, e-prescribing was a figment of most people's imagination. Yet 10 years later, we see this, very, very high numbers of even controlled substances being prescribed. One of the things that providers need to do when they're prescribing controlled substances is they have to register with a number of different government entities. Those government entities are now starting to connect up with each other. And so we're thinking about ways in the thought leadership community and the innovator community, how can we use some of these existing initiatives that are going forward to try to piggyback this provider directory problem solution?
Yeah, no, absolutely. And before we get too much more into the mechanics of what can be done about the problem, I want to back up to that first question. So obviously the legal contract, if you will, the commercial contract, really interesting take on, and I hadn't heard anybody refer to that at all prior to today. What I've been seeing in my research on the problem and just generally in the work that I've done, that the issue goes back to access for individuals and just simply being able to find the doctor that they're looking for, get in touch with them. There was a health affairs study that just came out on their July issue, and they cited that in their secret shopper experiment that they did, that they had about 30% of the time where they could not get an appointment with a primary care doctor that was on that list. And it was for a variety of reasons. Believe it or not, only 10% of those failures were due to them getting in touch and the provider just not accepting new patients. Most of them were because they weren't getting callbacks. The numbers on there were incorrect. The providers that were on there were actually not participating in the plan. Those all contributed more to it. So really, it's also from the regulation standpoint an important access issue. Any thoughts on that?
Yeah, access absolutely is the principal problem. The concern that I have is if we don't all think about this from a fundamentals perspective, like what is the first principle? The first principle that people are being fined for is that you are saying something and writing it down that you're going to do it, and then you don't do it, right? Mm-hmm. So yes, access is an issue. And even if you had the access, they may not say that they're accepting new patients, and there are a variety of different concerns. What we have to say here is, and this is where, we've brought up other technologies in the past in HCBiz conversations around blockchain and integration technologies. This is fundamentally a problem because the offer to a health insurance member from a business perspective is being made by the insurer. The delivery of that service is being done by the provider. Now, if the provider and the payer here are not linked, as close as possible, then that means that the health insurance company is offering a service that the provider is not willing to submit to, and now you've got a big problem. It's a legal problem. It's a commercial problem. All kinds of different issues are coming out, and the access. So when you look at it from a patient's perspective, they're just pissed when they walk in somewhere, and they're like, "Oh yeah, my insurance company told me that you're accepting new patients, or my insurance company told me you accept this insurance." And that's why I signed up to that insurance. And now all of a sudden you're saying you're not. If we don't think about the why things are the way that they are, we won't properly solve this. So we don't have to solve it with 100% accuracy for all time's sake. We have to say, what are the 2 or 3 things that a new plan member or someone that has accepted signed on the dotted line to say, I'm now on this plan, what do they need to do? If we can get this process started earlier in the signature side, where they're selecting their plans and selecting, if selecting a plan required you to, at the same time, pick your doctors at that time, it would solve parts of this, right? But we can't do that. We can't say, you're going to sign up for an insurance plan that you might not use till next July, but you have to pick your doctor today. I mean, that's crazy. Nobody would do that. Right. Those are the kind of things that we really have to think about. It's a really, really hard problem to solve. The core databases are sitting in a variety of different places, but how do we actually coordinate this in a way that we can all be commercially and legally viable and accurate on, but at the same time have solid and great customer satisfaction? Because the patient is pissed at both the provider and the payer. They can only blame the payer because that's the deal that they signed, right? They signed the deal with the payer, not the provider. So it's a very difficult problem to solve, but some options are available.
Gotcha. And then just to expand outside of it from the payer perspective a little bit, just the operational sense of the actual delivery of care and how important having good provider directories is for that exercise. A quick story is a health home administrator told me they had a patient come in. Patient was diagnosed with some issue, just needed a pretty low-key outpatient procedure done. And obviously they're on Medicaid in the health home. And they sent them to the navigator. The navigator was unable to find someone that was willing to perform that procedure under Medicaid. Told the patient, give me a couple days, I'll get you set up. Didn't do it in time. The small issue turned into a big issue. Patient ended up in the ER at the public hospital. and ended up having this procedure now done under duress in the emergency room. Emergency room set them up with a referral appointment on exiting the hospital. Patient shows up for the referral appointment, got turned away because that provider didn't accept Medicaid. Patient ended up back on the ER. So this problem kind of like this, the story always encapsulated the issue here on the operational side, to a T. It's like, we've got this person who we got them right where we wanted them to be. We had them at a health navigator at a health home with a diagnosis. We knew it needed to be done. And because of our lack of good data, they ended up in the emergency room. This thing ended up costing the system way more than it ever needed to, and ended up putting this patient through a whole bunch of agony and misery that they didn't need to go through. And it's like, basically it was achieving the opposite of the triple aim, all because they didn't have good provider data. And you can go into that, the lack of a provider who accepts Medicaid, that's a separate issue. But the fact that this person couldn't clearly identify that they either did or didn't have a place to send them for that referral, that's the issue. And that's where it ties into this, is like, we need that in healthcare. And when we get people to the right place, we got to be able to take care of them.
Yeah, and I think this story also exemplifies another pet peeve of mine, is when we talk from a business of healthcare perspective on interoperability. Think about this idea of just saying, what if we don't focus on 100% interoperability and go crazy about the fact that everybody should be connected to everything, and let's just solve some fundamental problems. Like, this is it's a fundamental problem that if you can't get the access, the rest of this is nice to have. So could it be just like our friends at SureScripts 10 years ago said, the interoperability we care about most is purely on e-prescribing and everything associated with that. And lo and behold, after MIPA and a whole bunch of other things, 10 years later, we're getting a significant benefit out of that thought process. What if the next 5 years is about focusing on network accuracy, network adequacy, network access through provider directories? Now, this seems like it's a hard problem. We've already described it as that. But it's one that's fundamentally solvable because the data already exists and needs to be regularly updated now. It's not like the data, we don't know where the data is. I mean, providers, we know who they are in general. They need to be, their data needs to be updated regularly. So this basically screams out for a collaborative environment where centrally CMS, I mean, if they had enough money and time to spend on it, CMS by itself could potentially solve this, because they pay out 55% of all claims, and they may just say, if your data is not accurate in the provider directory, thou shalt not get paid. Now, there's a lot of fraud, abuse, and other things associated with the way that Medicare billing occurs, but a lot of that is because of this data. Like, if you're not supposed to be seeing this patient, why are you allowed to charge for them? So when you look at what AHIP is trying to do, when you look at what the Innovation Lab is trying to establish and going forward, there are a lot of good news. Is there are a lot of companies, very smart, big players that are starting to move in this area. Now the question is, where is the demand, right? Up until 2016, literally January of this year, the demand side of the inaccuracy, of fixing the inaccuracies, was purely on the payer side. Now, there's actually a new program called PCP Plus, the Primary Care Plus program, which you and I chatted about in previous HCBiz episodes. It used to be that payers only had to worry about network accuracy, adequacy, et cetera, for their providers. But now with PCP Plus, unless the provider data is accurate, bonuses will not go out for PCP Plus to the proper provider. If your ACOs are to make money, you as providers in that community have to have your provider network adequacy and accuracy data up and running. So I see 2016 maybe as a pivot year that people finally get the idea. CMS is serious with their $25,000 per whatever, right? That they haven't actually described nicely what that
sounds expensive, however they define it. Yeah,
however they define it. California, in April, March and April, making this case. PCP Plus is the first time we're going to see this matter more than ever to anybody who wants to make bonuses off that program. So now that the foundations have been laid of the problem, And we have, CMS is, it's not like CMS is ignoring this. They're trying to figure this out. They're trying to work on it and doing great. The FHIR community has picked up pace and started to say, okay, we'll provide provider directories and other things through FHIR and some of the other items you wrote in your blog post yesterday. So I see this as a pivot year. And now let's see if we can get the big boys to all play together and say, just like we got together and now we have better interoperability for e-prescribing, can the solution associated with interoperability for provider directories alone, right? We're just talking about maybe 25, 30 elements of data. This is not 300, not 3,000. We're talking about 25 to 30 pieces of data. What could we do to make a dent in this in 2017, 2018 might be a great place for us to start.
Yeah, right on. And those, those 25 to 30 data points too are largely non-competitive, many of them publicly available. And it's like competing on that data, like competing on the accuracy of your spreadsheets within your payer. It's just, it doesn't make sense for that to be an item that they're going to compete on. So I think that's what opens up the door to the collaboration here. And certainly the pressure from the providers to not, they don't want to, as we said, report to 20 different places, feeling that pressure, feeling the pressure from the government. It definitely makes sense that the payer community are the ones that are starting to take the lead on this. And to your earlier point about can we focus on the next 5 years on this one particular issue or this particular class of issues? I'm with you 100% on that. And that's kind of my opening joke there about, too often in healthcare you hear, if you can't solve all of my problem, I don't want you to solve any of my problem. John Halamka had made that case earlier this year, I think around HIMSS. He and Mickey Tripathi were going around HIMSS and kind of trying to say, let's pick 5 use cases, 7, I don't remember what their number was. Let's pick these 5 or 7 very meaningful things and just do those. Because ubiquitous semantic interop, while that sounds amazing as a technical person, like I have a hard time believing that's ever going to actually happen. But like right now, what would we even do with it? It's, if we could achieve that, what would we even accomplish? We'd probably accomplish those 5 or 10 use cases, and then we'd have a bunch of nice to have data laying around that we weren't doing anything with. So
yeah, I think Chuck is making that same point that you are, Don, on the chat here, saying skip the boil the ocean syntactic and semantic interoperability effort.
Exactly.
Focus on workflow interoperability. And if we said that there are maybe 9 or 10 workflow steps, right? Knowing whether you're accepting a new patient, signing the patient up, onboarding them, referring them. Like if you took these kind of workflow steps, again, similar to what we did with e-prescribing, between the big players there, focus on the 9 or 10 workflow elements like Chuck is saying. Joe asked a little bit about whether that means the last mile. I'm not sure it means the last mile per se, but a focus on very, very specific use cases where these commercial contracts can be voided. I mean, this is a big deal. You're offering something to someone in which you can't supply the service. I mean, that's like commercial fraud 101. If we just say, well, how do we help companies say what they mean and mean what they say? What are the 9 or 10, 15 little workflows that we need to do there? And focus our interoperability efforts on existing networks, mind you. Like, why go create something new? I mean, if SureScripts has a network, go use it. If Change Healthcare has a network, let's build something on there and get this moving in a way that says we don't need new infrastructure. We just need to agree on the messages. Even if it's FHIR as the protocol, that's perfectly fine. We just need a pathway to the data from a variety of different places on FHIR. So the good news is of all the different problems that we have, this is technically solvable. It's got fines associated with it. I mean, it doesn't get any better than that with respect to a business need. So if we can contemplate, and this is one of the struggles that we're seeing as we're talking to plans on a regular basis, is how do we tell them, and they all want to solve it. Nobody says, oh yeah, we're done with provider directories. That's all a problem for us. No, everybody has this problem. We from the healthcare business technology community, as well as the IT side, are not coming back to them with specifics that says, here's what you should do from a technology perspective. And so they have to resort to the phone, the fax, et cetera, because that's the only way that it'll work today.
Yep, absolutely. So So I think that establishes the problem pretty well. And I'd like to start getting into talking about what are the opportunities for collaboration, what's starting to happen out there more broadly first, if you will, from what you're aware of, and then we can drill into specifically what's going on at AHIP with some of the pilot programs they're working on. So I guess across the board, we know payers are getting involved. Who's getting involved? Who's kind of leading the charge here that you see across the country? From various groups, be it commercial payers or be it for-profit businesses that are coming in and trying to provide these services.
Yeah, I think you did a good job yesterday, and it's also in the link below. So you've got the Better Doctor and Availability, who are being used as the pilot program managers. And then there's a list of the health plans that are participating in the pilot. That's Anthem in California, AvMed in Florida, Blue Cross in California, Cigna in Florida. So there's a number of health plans that are participating in the Availability and Better Doctor pilot. That's a traditional model that says, instead of everybody wasting money on trying to repeat the same thing over and over again, and each health insurance plan going and calling each doctor on their own. So let's say there are 10 plans, the doc gets 10 calls per quarter. Instead, the pilot that AHIP is running now says, let's funnel these through the Better Doctor and Availability pilot and see, can it reduce the number of calls to the physicians to a lower number? And can we get more accurate data out of this? And I think I don't see a chance of failure of that pilot. I mean, the only time the failure would occur is if phones stopped working and faxes were delivered and emails couldn't get through. I mean, it's just going to be one of those things which says, of course we should do this. Of course we should centralize the administration. And that I think AHIP is doing a very, very smart thing, and the participants are doing a smart thing. However, that's still a problem that's being solved in the traditional way, which is the only way we have today. What I'd like to do going forward, and this is what we're planning, which I can't share all of the participants yet because they haven't said it was okay to, but we've got some very big players who want to try to connect at the, not purely the semantic interoperability level for 100% of the data, but semantically connecting provider data and whether or not they accept certain plans or accepting patients, new patients, and just the basic like 20, 25 fields that I was talking about. Using existing networks, no new networks. So the dual-sided networks are already available for claims processing, for e-prescribing. We're just going to create a FHIR-ish kind of protocol that allows us to package up that data and pipe it through the existing networks. That will be, hopefully we'll be able to announce something later this year, but I think it's going to be very important to keep an eye on and get any ideas from people that say, yeah, we're having a great time with FHIR, it's working well. The Availability and Better Doctor pilots, here's what's working well, and here's what we would like to add. And so the good news is there's enough innovators that want to jump in and solve this problem. We have a technical set of solutions. It's a matter of finding the right number of pilots of alternative programs that are deeply embedded in interoperability rather than the kind of workflow-oriented models we're talking about, centralized administration models that we're running on the pilots at AHIP today.
Yeah, and what I really like about that solution is that you are relying on existing infrastructure, things that are already in place, which huge win right out of the gates there. And then the fact that if you can do that and you can leverage in some way the existing workflows, so solve the problem without adding new tech, without adding new workflow, I think that's kind of the holy grail type solution when you're trying to work a problem like this out. So that's a really interesting approach. So can you talk more specifically about what has gone on with what has been made public already with the AHIP and the groups in California and elsewhere? Where are you all in that process with Better Doctor Availability? Is that infrastructure in place? Is that data flowing, or where are you?
Yeah, the data, so as you know, Better Doctor and Availability are existing vendors in this field. They do a good job in the areas that they're already entered. And so the data is flowing, the work is being done, and that's moving along. And the success is really dependent on which plan you're talking about. So the ability for them to properly coordinate with Availity and Better Doctor, and then how they can get their data out of their own systems, push the data into their own system. So even this seems like such a simple pilot, but there's a lot of complexity. The business case associated with it, the idea of using multiple plans, combining and using grouped services for administrative sharing. So this is basically a shared service model rather than a technology interoperability model. So there are multiple solutions here. So in the shared service model that we see today, it's actually going reasonably well. So, people are they're going to save money. The doctor's going to get fewer calls. Now, the data I don't think is going to be delivered up until, I believe it's going to be early next year when the pilot data is put together and we learn specifically what was good, what was bad. But I'm thinking, Don, you and I can reach out to some of these plans and maybe get some of their leaders on our call and ask them this question.
Yeah,
how did it go? What's not working? Because it is, unfortunately, it's health plan specific. If we just went and talked to Availity or Better Doctor, they do this for a living. They know how to do that. And It's a matter of making sure that the plans properly are connected up and they know how to consume and put data into these systems.
Yeah, and that brings up a really interesting point in the consumption of the data. Because when you think about this problem, you tend to say, okay, well, you've got health plan A needs the data and health plan B needs the data, and they both need to get it from the doctor. But what actually happens in reality is within health plan A, there's a credentialing department and an enrollment department, and there is maybe they have their own kind of like IPA type program going on, where they have a physicians group, and they've got all of these different groups within that payer that are all separately from one another managing this information. So now it's not two payers coming at this doctor looking for updates. It's like 7 payers coming at it because there's like little subgroups within them. And what I'd love to talk with some of these leaders about, if we could get them on, is how are they leveraging now this central source of verified good data? How are they utilizing that as a way to solve some of those kind of cultural problems in-house, where everybody wants to keep their own spreadsheet and everybody wants to keep their own, access database or CRM or whatever the case may be, and kind of eliminate all of that work? If you, I referenced the health affairs study in the blog post, and one of the quotes from, it was one of the California plans, is like, we've got 30 people working on this all day long, every day, trying to get this data right, making these calls and doing all this work. It's like, how are they leveraging this, centralized way of kind of reducing that workforce or reappropriating that workforce to do something more productive? And I think that's like the second wave of this, because even if AHEP's 100% successful at delivering that data to the door, if that second problem isn't solved, it again is going to be kind of for naught.
Yeah, I think you hit the nail on the head there. And that's why I was mentioning that the success of the pilot in this particular case is largely determined by how far the internal enterprise IT consolidation efforts have gone within the payer. So if you're talking about a small payer, they probably have a single or 3 or 4 or 5 systems. You talk about a medium or large payer, they have dozens of systems with the same data. So you hit the nail on the head exactly, where if a plan wants to benefit, they should start just working internally to centralize their own systems around one or more provider directories. And that's really where companies like Availity or GE or others come in. They have these solutions, and they don't work well across institutions for all the problems that we've talked about, but you can get them to work inside your institution first. So get your intra-institution connectivity going first, using a variety of different existing tools, and then worry about inter-institution capabilities with multiple stakeholders and multiple institutions. So what we notice is when we go in where we see payers who are already well connected internally, they move very rapidly. If they're not well connected internally, that's where things stop. And then they say, well, this is a problem on the outside, the data is not available, et cetera. But like you said, even if it were and everything was working well, you still have a problem internally. Again, going back to what has worked in the past, like e-prescribing or claims processing, they needed to be centralized internally first before coming onto the network. And we've seen that story play over and over again.
Yeah, absolutely. So we're getting close on time here. We wanted to end a little bit earlier before 1. So I want to give you a kind of closing remarks opportunity here. Anything else you want to share with the group about what you've been working on in the space or what you've seen? Yeah, I would definitely be interested in looking at some follow-up opportunities with these other groups.
Yeah, I think that to me, the most exciting part here is that these new requirements around MACRA, MIPS, CPC Plus is putting on much more burden, and I shouldn't be excited about seeing more burden placed on already overburdened providers. But the one part that is exciting is that now this is a problem that providers have to solve for themselves first. And so if they get together and say, okay, guys, I need to connect with you, you need to connect with me, here's the data we're willing to share, and they start the provider-to-provider accuracy solutions, then payers can glom onto that. They can help pay for the solutions, help establish and move those initiatives forward. Because up until a couple of years ago, and certainly officially up until January and then March and then June, and again, remember January was the CMS fines, March and April was the California, and then we had CPC Plus in June and July. MACRA and MIPS are coming this year. I mean, in 2016, you've had 5 or 6 very big, real efforts at now this provider accuracy, and provider data management is going to be just as big a problem for providers as it is for payers and everybody else. And that's what I think is going to help move this along in 2017 and 2018, along with some of the work that AHIP is already doing really well, plus the ability for us to get together and use new protocols like FHIR on top of existing networks like Change and SureScripts, and be able to knock this out of the park within a few short years.
Awesome. So yeah, with that, I say we move to wrap it up. But it was a good first look into the problem. I hope you all got something out of it, and I hope you all be interested in learning more if we bring on some more folks. But yeah, again, just the payoff for this is huge. If we can put even a small dent in it, I think the kind of ripple effect that'll have on the downstream problems that won't happen, I think we'll get a lot more bang for our buck as a country by solving this problem than anybody could really even estimate accurate at this point. So huge opportunity, one of those super boring but super important, and something that needs to be resolved. So as always, thanks for your time today, Shahid, and thank you all for joining us. Hope to see you all again next week around noon Eastern. We'll as any of you tweet chatters noticed, I did not do a good job of doing both of these things. I don't have enough cycles.
We fell, literally, we cannot be multitaskers, right?
No.
Either we can talk or type, but not both at the same time.
Yes.
So valuable lesson learned. We're not going to be able to pull that off.
I knew that about myself, but I wanted to at least give it a shot and see if I could fall into it, and I just couldn't. So I apologize to anybody that was waiting for us to really start chiming on the tweet chat, but always worth experimenting.
Yeah, that's what I think over the next few weeks, definitely experiments will continue, and we'll keep everybody posted. But we're back to weekly, so hopefully Fire Talk will get this the tech side of this worked out, so we don't have issues in the future. But Fire Talk seems like it should work out fine and going forward.
Yeah, I quite like the platform, other than my audio issue today, but I'm sure that's on my laptop, so I'll work that out.
Great.
All right, great. Thank you, everyone, and we'll see you next week.
All right, thanks all. Bye.
Bye.